Hey guys, good afternoon, everyone. All right, so today we're gonna do some some tips about uh, what can you do when you need to do ischemic eval and when you need to do ischemic eval and what you have to do with the data that you get from the ischemic eval. So let's talk first about what are the modalities that we use for ischemic eval. Ischemic eval, when you try to assess if there's any decrease in the oxygen supply to the heart, and decrease in the oxygen supply to the heart is mainly by coronary artery disease or history of myocardial infarction in the past, and the modalities that we utilize to check for ischemic eval is the simple EKG test, EKG stress test. And the EKG stress test is specific and sensitive is about 60% of patients. Now, EKG stress test, it should actually have some requirements to be able to do it for your patient. Number one is the functional capacity. Is your patient going to be able to do more than 85% of maximum predicted for age? And how you calculate maximum predicted for age is 220 minus your age. So you really need to be able to do 85% of maximum predicted for your stress test to be accepted as ischemic eval. So your patient has to exercise and has to be able to do exercise. And this is actually not what we see in our patient population. I can tell you that most of our patients, probably close to 80 to 90% of them, go through pharmacological stress test and nuclear imaging with it to be able to identify if there's any ischemia or not. So this is the first, the EKG, and if you have somebody with left bundle branch block, you can do it. If you have somebody with history of coronary artery disease who don't like to do it, you have to have functional test and you have to have imaging test with it. If you have somebody with history of myocardial infarction, you can do it. If you have history, somebody with WPW, you can do it. So, healthier people that you think the likelihood of having COD disease is low, you can put them on treadmill and see their EKG response. Now, we don't only use treadmill EKG for ischemic eval, but sometimes we use it to assess functional capacity and to assess if there's any chronotropic incompetence. In other words, if the sinus node is able to maintain good rate to provide enough oxygen supply to the heart and the rest of the body. And you have to have at least 70% of maximum predicted for age to label your patient as a chronotropic competence. Otherwise, pacemaker may be indicated for these patients. So again, the treadmill EKG is very helpful in giving us a lot of information about functional capacity and giving us information about the competency of the electrical system in the heart, as long as the STT changes that you can identify, and that will help you in finding out if there's any ischemia or not. Now, in women before menopause, because of the estrogen, you may identify STT with changes because of this stress test, and that really does not usually correlate with coronary artery disease. But that's a really different topic. Just keep that in your mind. Now, the imaging test, the nuclear imaging test, what we use is the system EV stress test, and it is nuclear tracing that it will help you identify areas of decreased supply, and the decrease in the supply of the isotope in certain areas will correlate with blockages in the heart arteries. And remember that we said 60% accuracy or specificity and sensitivity of the plain treadmill stress test, the imaging part will increase it to about 70 to 80%. So the nuclear imaging part, you can use it either with adenosine, Lexiscan, or exercise stress test with imaging part, and the ischemia in that case will be identified, and based on the magnitude of the ischemia, then management will be assessed. The other part is other ischemic eval modality, which is the stress echocardiogram. So you give your patient dobutamine, or you give your patient, you put your patient on treadmill and you check the wall motion on echocardiogram. That's called stress echo. It's actually pretty accurate. It's about 80% accurate, and sensitive and specific as well. The other modality also, the MRI, cardiac MR, can assess mainly viability, and also will identify areas of ischemia. But the problem is you can't stress your patient. Sometimes we can give actually dobutamine in this kind of patient population, but it becomes very expensive and time consuming. So we leave the MRI only for cardiac MR, mainly for actually assess viability. Now, when do we ask for ischemic eval? We ask about ischemic eval in patients if they are symptomatic. So if you have intermediate likelihood or probability of having coronary artery disease, in that case, based on Bayes' theorem, you can do stress test, and either if the stress test is abnormal, in that case, you can do heart catheterization or CT angio to rule out or rule in coronary artery disease. And if this stress test is negative, in that case, your symptoms are probably not related to coronary artery disease. So if you have intermediate risk probability, if you have somebody with chest pains, but sometimes comes with stress, sometimes comes with exercise, it's not very typical, but guy is diabetic, little bit of hypertension, some family history, in that case it's reasonable to do stress tests in that patient to see if there's any indication for ischemia. Now, if your patient, for instance, has history of coronary artery disease, and this patient has been having typical angina pectoris, stent was done 10 years ago, he's diabetic, he smokes, and he's been having chest pains lately, and the chest pain is typical, worse with exertion, relieves with nitroglycerin. In that case, the stress test is not very useful. It can give you risk stratification, but regardless of how you feel about it, you may need to send your patient for left heart catheterization, because the likelihood of coronary artery disease and stent restenosis is extremely high. So keep that in your mind. If your likelihood of having coronary artery disease is very high in your patient, in that case, probably heart catheterization or CT angio is the way to go. Stress test will give you, kind of prognostic information, risk stratification, how large the area affected, if there's any indication for a viable myocardium, and so forth. But still, if you need to rule in, rule out coronary artery disease, in that case, left heart catheterization or CT angio is the way to go. Now, in some cases, you ask about ischemic eval in patient before surgery clearance. And this actually is a very controversial topic, but I really want you to think about it the way you think about any patient coming to your office. In other words, if your patient is symptomatic, having chest pain, chest tightness, diabetes, little bit of tobacco history, some family history as well, EKG doesn't look right, and they're asking you to clear this patient for hip or knee replacement, regardless of the hip or knee replacement, probably you're going to send your patient for some kind of ischemic eval, which is, the nuclear stress test in that case, pharmacological nuclear stress test. And the reason you have to do that um, is, you never know. You may identify coronary artery disease in that case, and you may change your management, either send your patient for stenting or just optimize medical management before you send your patient to surgery with, a lot of fluid shift. So the pre-op clearance cases, you have to take into consideration your patient, what kind of patient, risk factors and so forth, if they have cardiac symptoms or not. You have to take into consideration as well the risk of surgery. Now, if your patient coming and having colonoscopy, although it is low risk procedure, but your patient has been having chest tightness at times and you think that there is something going on, regardless of how low risk the procedure is, you really need to treat the heart first. But if you're having somebody who's having, for instance, knee replacement or cholecystectomy, and EKG is a little bit abnormal, but the patient has, good functional capacity, no major issues. In that case, you really don't need to risk stratify your patient by doing stress test. So you have to think about it this way. If you think the stress test, the ischemia eval is going to change your management, in that case, do it. If you think that the ischemia eval is not going to change your management, don't do it. And, remember always that mild ischemia, still no big deal. When it comes to intermediate large areas of ischemia, along with decrease in ejection fraction and, other aspects, this is when that might indicate that the coronary artery disease is significant enough that you have to do heart catheterization and you may need to fix it. So this is the pre-op clearance. Sometimes we really use ischemic eval to risk stratify our patients. In other words, your patient has coronary artery disease, and you know that there's some stenting history as well. So your patient is asking you about, what can I do in terms of exercise and so forth. Stress test in that case may give you an idea about, if the coronary artery disease is causing enough decrease in the perfusion of the myocardium that you have to worry about or not. It also assess your medical management. For instance, you have patient has coronary artery disease, had PDA 80%. You started medical management and you want to assess if your medical management has been helping your patient. So you may re-stress your patient to identify if there's any change in the ischemic burden that the patient has compared to the previous stress test and so forth. So it can really help, guide management. So for instance, your patient is taking metoprolol, heart rate 80, blood pressure 150. Your patient is taking also ACE inhibitors, a little bit of nitro, patient has good amount of statin, but still having some ischemia on the stress test. In that case, you may just try to medically optimize your patient better, lower blood pressure to less than 130 systolic, give them some Farxiga or Jardiance SGL2 inhibitors, uptitrate the metoprolol to keep heart rate around the 60s. So it can guide your management based on what you have in terms of stress test results. So it's a kind of art of medicine when it comes to dealing with stress test results. I really want to let you know, guys, that if you do ischemia eval and you find abnormal stress test, it's not always you have just send your patient to left heart catheterization. So you really need to look at your patient and find the ischemic burden and the symptoms of your patient. They did multiple trials. The last one was the ischemia trial, and they said, okay, let's see if you have ischemia on the stress test. We'll send you for CT angio, and we'll randomize patient to stenting versus no stenting. Guess what? Even if you have 99 or 90% stenosis in the LAD, I'm not talking about 99, probably 99 is just remarkable. But if you have 90% stenosis in the LAD, proximal LED and you have a little bit of ischemia and we randomize you to medical management versus cath, guess what? There's really no difference in outcome. So the cath people, the stent people may have less angina pectoris, but the hard outcome when it comes to MACE, which is, the major cardiovascular outcome from stroke, heart attack, CHF, hospitalization, and death, there's really no difference. Why is that? Well, because medical management becoming very, very effective nowadays. We don't only have beta blockers, calcium channel blockers, ACE inhibitors, ARBs, good statins, but we also have the SGLT2 inhibitors, the aldactin, the medication that can control blood pressure and decrease the wall stress of the heart and the blood vessels, and actually minimize the likelihood that you're going to have plaque progression and bad outcome down the road. So it's not actually it's not opening the artery is the solution in coronary artery disease. Is really how to make the plaque stable. When you do stenting for these patients, you trap the plaque between the stent and the wall of the artery. You don't actually melt anything, right? And it's actually the same way when you try to medically optimize your patient, try to adjust their lifestyles and put them on the right medications and make the plaque stable. So the plaque is not going to rupture and the likelihood of having acute myocardial infarction becomes extremely low. So it is nowadays, it's art of medicine where you work with your patient to try to minimize the risk. If they are smokers, work with them. If they are diabetic, try to control diabetes to A1C target less than 7%. We're becoming very, very actually familiar with the effects of the SGLT2 inhibitors, the Jardiance and Farxiga, and we see great results with these medications. So try to use all these tools before you think about sending your patient to the cath lab and try to do stenting and interventions. Now, when it comes to nursing home patients, you're dealing with elderly patients, and with all the data I told you about the ischemia trial and others, having a little bit of ischemia, that's no really big deal. The key point is your ejection fraction to be fine. The key point as well is for your symptoms to be controlled, right? So as long as you don't have indication for acute coronary syndrome, medical management actually is superior to everything else. So you have 85-year-old patient and you think that there's history of ischemia on the stress test and everybody is panicking. No. Number one, this patient made it to 85 in spite of this ischemia. Number two, we have a lot of tools in your hands. Conservative management, medications, and probably going to have better outcome than sending your patient for left heart catheterization. That's going to get complicated with probably, bleeding or stroke or stuff related to the procedure itself. So ischemia might not be needed to be evaluated in elderly patients. And if you have a history of ischemia, you can treat that medically unless your patient is unstable hemodynamically. And it's extremely unlikely that the ischemia is going to give hemodynamic instability, i.e. VT, VF, or extreme hypotension. So try to all this old cardiologist mentality of ischemia equals heart cath and panic about it is not actually valid anymore. We have multiple clinical trials. I told you about the ischemia trial. There was Courage trial in 2007, and they randomized people to medical management versus stenting. And actually, I met the one of the PI for this study. He retired. He was at Mayo Clinic, and he told me it was freaking very difficult to take this 90% stenosis proximal LED and try to randomize this patient to just medical management only. And that's 2007, or probably before 2007, because it was published in the New England Journal of Medicine 2007. So it was before that. Guess what? 2023, we have actually better medications, better statins, better beta blockers, better SGLT2 inhibitors, better better understanding of hypertension. And in that time, in 2007, there was no difference between stenting versus medical management. And now there's really no difference between stenting and medical management. So always keep in your mind that in these elderly people, medical management actually is just reasonable to do. And just you need to have interventions after interventions, medication after medication, and try to adjust doses to medically optimize your patient